Welcome to Progenesis Academy webinar, session 41. Today's topic is implantation failure, causes and possible solutions. We have two excellent fertility specialists with us who are going to help us address some of the questions asked live from patients. We have Dr. Roseff. He's a fertility specialist at IVF MD, Boca Raton, Florida. And we have Dr. Sharara, fertility specialist at Virginia Center for Reproductive Medicine. Thank you so much for joining us.
Thank you for having us.
Thank you for having me.
Very good. So I'm going to start my first question before we get any other questions from the audience. And if you guys can help us define what implantation failure is. And I'll start with you, Dr. Roseff, and then we go to Dr. Sharara.
Well, when you talk about implantation, I'm assuming we're referring to embryo, following embryo transfer. I mean, natural conception, pregnancy needs to implant in the uterus, but I don't think that that's the focus tonight. I think we're focusing on embryos and embryos created through in vitro fertilization that fail to implant. And can you go over the question again, Nabil?
Yeah, so if you can just define, how do you determine if a patient has a recurrent pregnancy loss or just implantation failure in general? How many?
Some people look at implantation failure as repeated failure of embryo to implant in the uterus following embryo transfer. I'm a perfectionist, and I just want everything I do with my patients to be one and done and successful. So for me, a single embryo implanted into the uterus that does not implant, no positive pregnancy test, is implantation failure.
Fantastic, thank you so much. And that you define it as how often that should happen when you start suspecting that, you know, that there are factors that play into that implantation failure. It's not just, you know, it could be multiple factor, of course, but how do you, at what point you start looking for a deep analysis of what is going on?
The definition has changed over time, and people in the past, experts said we needed to have 3 failures, and then it changed to 2. And I think that we start to get, look, no one has 100% success rate. No one has 100% implantation rate of embryos. So if we implant one and it does not implant, we can't say that there's a problem with implantation. So it's usually repeated embryo transfer with negative pregnancy test, no implantation. And again, the definition has changed over time from multiple transfers that have failed to a few transfers that have failed. And again, I look at one transfer that failed. Again, no one has 100% success rate, but if it failed once, I need to think about why it just didn't happen. Is there a problem? Is there something in the way of embryo implantation? Or is it just simply that it just doesn't work every time? Everything was perfect. Every I was dotted and every T was crossed, and it just didn't work. So there are many, many, many factors that affect embryo implantation right from the start. And I can't speak for anyone else other than what I do, but what I do is try to so-called level the playing field right from the start so that the first embryo transfer will be successful. Fady, do you agree with that? Disagree with that?
I mean, the only thing, I completely agree, Scott. The only thing I would add is now, because we're doing so much PGTA testing beforehand, it's a transfer of a euploid embryo. Or obviously, if you're talking about a patient who's younger than 35, it's a transfer of a single embryo.
Well, we're doing single embryo transfer across the board. It's very rare that we have more than one embryo transferred. Maybe we can talk about genetic testing, PGTA of the embryos. Maybe that would be a good place to start. because in my opinion, and I would assume that you would agree, one of the biggest reasons for failure of an embryo to implant is genetic error in the embryo. If the embryo is genetically abnormal, then I believe that it's more likely that that embryo will not implant. And again, you'll tell me about your practice, but in our practice at IVF-MD, in the past, we were genetically testing embryos with only certain conditions. We would genetically test the embryos if a patient was older, or if a patient had prior non-tested embryo implantation failure. Okay, now let's test the embryos. Or if a patient had a history of recurrent pregnancy loss or aneuploid genetically abnormal pregnancies. Pretty much now, most of our IVF patients across the board, irrespective of history, irrespective of age, most of our patients are having genetic testing of their embryos. It does appear, in my opinion, to increase the odds of implantation. It does appear to reduce the odds of pregnancy loss, miscarriage. And so you're right, when we're talking about embryo transfer, we're mostly talking about genetically tested embryos for what's called aneuploidy. And most of our patients are doing that. Are you doing mostly single embryo transfer as well?
I mean, that's probably 95%. Every now and then I have somebody who comes in and I can't twist their arms enough to transfer just one, but those are very few and far in between.
Right.
I mean, in my practice, I don't push PGTA unless women are above 35. Granted, I have very few patients that are younger than 35, especially these days. Because if you look at the the literature, there's really no proven advantage for women younger than 35.
Under age 35, right?
Exactly. So for those, I tell them, look, this is the literature. These are the results. You can do it if gender is important, for example. If not, you may want to save a bit of money and just transfer one at a time. And if they're interested in doing PGTA, then perfectly fine. Anybody 36 or older, clearly I try to tell them to do PGTA. Every now and then you get somebody who just doesn't want to do it. I had a patient 2 years ago who was 42 and she refused to do genetic testing. Luckily, she conceived on her first FET, but that's an absolute,
exception, not the rule.
Incredibly unusual.
Yeah.
But every now and then you're going to get these patients. So, I know there are programs that are sort of 100% PGTA, but mine is definitely not that. I would say maybe 70, 80%. I still have some patients who don't want to do it. More and more, no question. I think the practice is shifting as we do this. I remember 5-6 years ago, I would have a lot of trouble convincing people to do it. Now they come in and they want to do it. So they're actually making our job so much easier. And we may get to a point where we're like Gattaca, basically all the embryos are tested before you transfer them back. And does it lead to an earlier pregnancy? No question about this.
Right.
Okay, that's one of the benefits at doing PGTA. But again, yes, less than 35, I leave it up to the patients to decide.
Yeah, most of my patients are older as well, the majority by far. But even the younger patients under 35 who need IVF for one reason or another are, for the most part, requesting to have genetic testing of their embryos. It's interesting. I think one of the reasons is because when my patients have an embryo transfer and conceive and deliver whatever gender baby they deliver, they're coming back having remaining frozen embryos from that first attempt. And they're asking if we can thaw them, biopsy them, refreeze, recryo them, so that we can see if there's the opposite gender in those leftover remaining embryos. And I think and we don't really want to do that. It's always best, if we're going to biopsy the embryos, to do it proactively, prospectively, right from the start on the fresh embryo, rather than the frozen embryo and thawed embryo. And so I think people are more knowledgeable now. They read a lot on the web, and a lot of patients are requesting PGTA right out the gate irrespective of their history or their age.
I agree 100%. That's actually a point I discuss with my patients beforehand. So I tell them, look, if gender is going to be important for you at some point in the future, please do it from now. We don't like to thaw embryos, biopsy them, refreeze them, and rethaw for a transfer. So do it from now, but don't come in 2 years and tell me I got a boy and I want a girl now and we have to do these things. We don't like to, play with these embryos more than we'd like to do. So biopsy, freeze, and be done with it, and we would know what the results are. So I am in complete agreement. I do exactly the same thing as you do.
So now back onto the topic of implantation failure, when we biopsy and genetically test the cells, we of course have to freeze the embryos. Years ago, we did a lot of fresh embryo transfer, stimulate, get the eggs under a scenario where the estrogen level is in the thousands, and grow the embryo for 5 or 6 days and do a fresh transfer. And the high estrogen, the high estradiol level in that stimulation cycle is what's called contragestive. High estrogen has a negative effect on the uterus. And when we do frozen embryo transfer, we're having estrogen levels in the multi-hundreds, not in the 2,000, 3,000, 4,000 range. And it is more physiologic and closer to what normally naturally occurs with conception. And I think that is potentially another reason why we can have better implantation rather than failed implantation. Years ago, we used to have patients with polycystic ovarian syndrome, and we would stimulate them. Their estrogen levels would get up into the 4 and 5 and 6 and 7,000 range. And 5 days later, we would put an embryo into the uterus, and an estrogen of 5,000 has a negative effect on implantation. So frozen
progesterone even more significant, but yet if these patients get pregnant, they hyperstimulate. That's the biggest fear in these patients.
Of course.
So yeah, it's definitely much more.
Implantation failure, I think we're doing better with frozen embryo transfer
100%.
compared to the days of fresh transfer. It's very rare that we have a fresh embryo transfer these days. It's mostly
I still do about maybe 10% in very few picked patients, but that's a rarity these days.
Very good. Let's take some questions from patients. We have some patients trying to put some questions.
Good afternoon.
Hello.
Hi.
Hello. Hi.
Hello. First of all, sorry about my English. If you don't understand something, just let me know, okay?
No problem.
Okay. I'm going to make a brief about my history. So I got my first IV transfers. Oh my God, my first treatment, and it was unfair because at the beginning, the doctor, he told me that he's going to put me some anti-concept pills. And so I got, when my menstruation coming, I did my job. And when I got the clinic, they say, oh, did you start the pills? And I said, no, nobody told me where is the pills, when I can find it. Oh, probably we are going to start the next month. I said, no. I don't know, because I'm doing my job. I think you need to do your job. So it was a confused, and I don't know at this point if I really need that pills or I really don't need it. I am 36 years old. I don't have any endometriosis. I don't drink alcohol. I don't do drugs, nothing. My husband is healthy, even is younger than me. He's 32. So in that moment, they say, okay, we are going to start just with the stimulation. So I got Menopur, I got Gonalef for 10 days. After that, I got Cetrotype. And they made they got my eggs, I don't know how to explain, sorry about my English. And they got
You mean retrieval? You had egg retrieval.
Yeah, they got 9 eggs from me, and everything, all the all my results, they say that it was good. My husband was good, was fine. They transferred those embryos at day 3. So they transferred me 2. At the beginning, he said that in his office, he transferred just 1. But at the end, he decided to put me 2, and I was happy with that, but I was agreeing. So one of them, the eggs was in 6, divided in 6 cells, and the other one was in 8. So they don't talk so much about numbers, about quality. So at this point, I really don't know. Probably when I say to you, because you are a doctor, you know what I'm talking about, I really don't know. So I went to my house, I did everything what I had to do. So I was very, very, very careful in that point. So at this point, I don't know if I really need those pills, and because they got a mistake and I got mad, they don't make me that treatment. They miss it from me, or for my eggs, from me, I really don't need it, or I really need it. Okay. At the end, the treatment, it wasn't good. So I feel that I don't trust anymore in that office. So I'm going to move on to another office. So my question at this point is, do you think that in those embryos that they transferred to me at the age 3, do you think that I should have to do a genetic test? Is possible to do a genetic test in the embryos just for 3 days?
Dr. Sharara or Dr. Roseff?
Go ahead, Scott. Start first.
So I'm at an IVF clinic in Florida called IVF MD, and overall we have the highest IVF success rate in the state of Florida, and certainly among the highest in the country. And we don't do day 3 embryo transfers. We haven't done them in years and years and years. ¿Estás en los Estados Unidos o en otro país?
Yes, I'm here in Miami, in Florida, and actually I'm going now with the office that you say right now. Yes, I'm going to move to that office, and I want to clarify something, because from the 9X, I didn't got anything. So I got those 2 transfer in the Thursday, and the other one I missed it.
Most IVF clinics throughout the United States have not done, most don't do day 3 embryo transfers. Years ago, when we did not have the capability to grow the embryos for 5 days or 6 days, sometimes we even grow for 7 days. Years ago, we could not keep the embryo growing more than 2 days or 3 days in the laboratory. The technology was poor. And so we used to do day 3 embryo transfers back years before it was day 2 embryo transfers. But anyway, years and years and years ago, we did day 3. And we used to take one cell, una cellula, from the 6 or 8 cell embryo and test the chromosomes, the DNA, the genetics on it. And that's the best that we had. It's the best that we could do. But there's a lot of problems with that, a lot. And so now we grow the embryo to an advanced stage of growth and development called Blastocyst,
yes,
which is por lo menos 5 días or 6 días or 7 días, where the embryo is strong enough, and it's between 150 and 200 cells, not 6, not 8. And we can take several cells off the outer edge of the embryo and test, and then freeze the embryo, and we can test the cells for genetic mistakes. But if you're in Miami and you were doing day 3 transfer, again, I have a lot of patients who live in Miami. I'm in Boca Raton, but I have a lot of patients who live in Miami, and we do virtual consultation. And so you're welcome. If you're already scheduled with our Miami office, that's fine. Or you can, if you want to switch and see me, I'd be glad to help you. I speak a little bit of Spanish, un poquito.
Yeah, it's okay. My husband anyway is gringo, but my English, I'm trying to improve. So
No, you did very well.
we are going to do it good. If we do that, we are going to do it good because for him it's going to be better.
And I saw Dr. Sharara shaking his head when you were saying day 3 embryo transfer or genetically testing day 3 embryo. So I'm going to assume that he would say the same. He'll tell you.
Yeah, I mean, I started doing day 5 transfers in 2003, and by 2008, 80% of what we were doing were day 5 transfers. I haven't done a day 3 in, I don't know, 10 years maybe.
Right.
Especially in a case like yours where clearly there was like misunderstanding early on. You didn't take the pill. Clearly that cycle was going to be a disaster. What I would have done is grown embryos to day 5, froze these embryos, then plan an adequate frozen embryo transfer. So by putting 2 embryos on day 3, which, I mean, even, you know, we don't do day 2 embryo transfers except extremely rarely when patients really try to break my arm into putting 2. Otherwise, we put just 1. But in a case like this, where clearly there was a problem from the beginning, the smart thing would have been to grow the embryos to day 5, freeze them, and then do a frozen transfer. So you're clearly left that practice, and you're going to a much better practice because you were not happy with how this whole thing evolved. You paid for an IVF cycle, and you have absolutely nothing to show for it. So when you go to a decent practice, this is not what's going to happen. And you're 36, so I would strongly recommend you seriously consider doing genetic testing. Do that, transfer a single embryo that is normal, and hopefully you will get pregnant the next time.
So do you recommend, for example, in my case, do you recommend that I needed the pills, right, previously?
Not necessarily. It all depends. I don't know what, neither Dr. Roseff nor I know what your AMH is, what your antral follicle count is, what your BMI is. So I tailor every patient in my practice has a completely different protocol. We all know no 2 women are alike. Why should they have the same protocol? So you will have a completely different protocol based on your specific needs. So we cannot tell you to go on the pill or not go on the pill until basically you've been worked up appropriately.
Yeah, I'm not here to talk about nobody. I'm talking about my experience. I'm talking about that I felt and I saw. When I was involved in that treatment, I was just inside. So I saw one door open, and I don't like either the lab. When I saw the lab, I started to search in Google how look like a lab for the in vitro, and I saw in the internet that was more technology that I saw. Okay. I really don't believe that from 9 eggs I didn't got anything. Because I am not the oldest woman for this treatment. I'm not the youngest, but I'm not the oldest, so I don't have any medical condition, nothing. Okay. But another question that I have, if you as a physician, do you have a patient like me, and the 9 eggs were dying from because you know that those eggs is not going to achieve the 5 day the day 5. So what do you do? Do you tell me, okay, you know, this time your eggs no works, we're not going to transfer because it's not going to be successful, or you try to do it, to put it at the day 3? I know that you don't do it day 3, but in that case that you don't achieve the full quality for the eggs.
No, we don't. I mean, first of all, we cannot give you any advice. So you really need to understand that part, because we don't know your situation. All we're hearing is what you just told us, but we don't know anything else about you. So we definitely do not do day 3 transfers. If you do another cycle, I would still push you to a day 5. If you don't make any day 5 embryos, there's a problem with your eggs, more than likely than your husband's sperm. Okay. So this is why we cannot give you any advice. It's all going to be based on your testing, which
I'll give you
what you.
Yeah. Switch, like Dr. Sharara said, switch clinics.
Yeah, no, of course, definitely no. Now, I was looking to go through inside the IVF MD here in Miami, but now that in this conference you give me this opportunity, and thought I'm going to talk seriously with my husband, because we are looking the best the best place. You don't realize how much bad I feel, because I start thinking in the pills that I don't trust, the treatment failed. You know how hard is this treatment for a woman? And when they told me no, I say, oh my God, no. Okay, but okay, we are going.
We do
I have
know
another
Dr.
question.
Sharara has a big heart, and he's a brilliant doctor, and he's been doing this for decades, and he desperately cares about his patients. And unfortunately, you were not his patient, you were not my patient. And again, our best advice to you is, if you were not happy or comfortable with where you were, switch.
Right.
Yes.
Switch. But the good news, I mean, if we can all tell you one thing, you're 36, so which means we are optimistic that you should get pregnant. Even in a cycle that was not optimal, you made 9 eggs. So I am optimistic. I'm sure Dr. Roseff feels the same way. So
Sure.
please do not give up, okay? Do your homework. You already did. Unfortunately, most people do their homework after they fail. People should do their homeworks before they start an IVF cycle, and then pick the best program they can go to. Just stay positive. We both feel very strongly that you have a very decent chance at becoming a mother. Do not give up. Okay, just
Hopefully.
stay positive.
Yeah. I'm going to keep it fighting. I have just 3 small questions, and that's it, because I know that I am not the only one.
Well, one second. We have a large number of patients that are already waiting. If you don't mind, I will put you on hold a little bit. I'm gonna go to the next patient, and then we will come back to you if we have enough time. Is that okay?
Okay, perfect. Thank you so much for the opportunity. Thank you.
Thank you so much.
Welcome.
Thank you. Appreciate it. And next patient, Riley, if you can.
Yep, I believe she's with us. Hello?
Hi.
Hello,
Hi
welcome
there.
to the program. Please proceed with your question.
Thank you. So just a little bit of background. I had 2 retrievals and got 1 embryo each. Both are PGA tested normal. I had 1 frozen embryo transfer that was canceled because my lining was only got to 6 millimeters. My second FET, we did oral and vaginal estrogen, and then 5 days of progesterone. And I had a missed abortion at 6 weeks, 5 days.
What was your endometrial thickness on that cycle?
It got up to like 7.8 to 8.2.
Okay.
And then we did another retrieval since we lost our embryo and only had 1 left. And I got 6 embryos, but only 2 were PGT tested normal. And we did a third FET, which we ended up doing 3 extra days of the oral and vaginal estrogen because my lining was a little bit borderline thickness. I got up to like 8.6 max on that cycle, and we did the transfer with 5 days of progesterone, and I had a chemical pregnancy. And so now my question is, the clinic is suggesting doing IM estrogen, but I'm wondering, is there anything that I can do supplement wise, diet wise, to help improve my lining?
What's your
quick
body mass?
question first. What was your lining during the fresh cycle? That the last one you did, what was the maximum lining you had?
8.6.
Not the frozen, for the fresh.
It was only between 4 and 5. It didn't get very thick.
So there's a problem there.
Mm-hmm.
Have you had an endometrial biopsy?
Yeah, did they do a hysteroscopy on you to look and see what's going on? Did they do an endometrial biopsy? These are important things.
So we did a hysteroscopy after my, before my first cycle, not transfer, but my first retrieval, and it was normal. We did not do an endometrial biopsy at that time. And
Critical.
Yep, very critical. You
Okay.
cannot do it without an endometrial biopsy, especially in somebody who has a thin lining.
Okay. We're talking about doing an ERA this time around. I'm assuming this is different. So should I ask for the endometrial biopsy on top
Yes,
of ERA?
I would do that first before you do an ERA.
Okay.
Because it's an easy office procedure. And if it shows endometritis, then you should take antibiotics for about 14 days. And then you can do the ERA. The ERA is going to allow us to do a mock cycle basically and see what your lining would be. I would strongly recommend, I mean, I've had experience with Viagra vaginally for over 15 years. And in some patients, it makes a difference. You can, do acupuncture if you want. Diet-wise, I'm glad you mentioned something. I would try to avoid anything that's inflammatory. I'm pretty sure Dr. Roseff agrees. But the endometrial biopsy would be the first thing I would consider. And take baby aspirin also. Take vitamin E, take 400 twice a day. I think that's important. But the first thing we need to do is to make sure you don't have endometritis.
Endometritis is an infection inside the uterus, inflammation, infection.
Okay.
Dr. Roseff, what's your inputs on this case?
Do you know what your body mass index is?
It's 20. It's 23.
23.
Mm-hmm.
And were either of you, when you had created these embryos, either of you using, well, maybe I can't ask this in an open forum. Although we don't know, nobody really knows who you are. So, because it just says patient, I think. So I ask all of my patients if they smoke or eat or
alcohol even,
or vape marijuana, cannabis. In a lot of states, it's medically legal. It is in Florida. They just passed recreational marijuana in the state of New York, I believe, yesterday. A lot of people are using THC, whether it's smoking, vaping, or eating. And I am finding poorer embryo success in my patients who use THC in any way, shape, or form. And I cannot tell you how many patients I see for second opinion or transfer of care who did failed IVF elsewhere, embryo didn't implant, or we miscarried or had biochemical pregnancy. Yeah, my husband was smoking pot while we were creating the embryos. Or yeah, I was vaping marijuana when I was going through the egg retrieval process. And I do believe, and I'm not saying it in a judgmental way whatsoever, that it can have a negative impact on success. So if there's any thyroid hormone, critically important for getting pregnant, holding the pregnancy.
Prolactin.
I cannot believe I get records from people who failed IVF where the doctor did not check their thyroid hormone. I did a second opinion today on an IVF patient who had failed 2 cycles of IVF elsewhere. And there's a hormone called prolactin, and her IVF doctor never checked prolactin. A high prolactin level lowers the chance of embryo implantation, and it increases the risk of miscarriage. And this was a woman who had not 1, but 2 surgical procedures for breast implant and breast augmentation. And that's a risk factor for high prolactin. And our IVF doctor never checked the prolactin level. Vitamin D has been found to be important for embryo implantation for the uterus to hold the pregnancy and maintain the pregnancy. I see patients who've not had a vitamin D level checked, and that's very important. And Dr. Sharara had mentioned about inflammation, that there are foods that are inflammatory. I actually measure markers of inflammation in the blood in my patients. And when there's high inflammation in your blood, it will either inflame your eggs or inflame your uterus. And that can result in certainly either failed implantation or miscarriage. And there are ways to treat this. So there are so many different possible reasons. Do we know the embryo quality, the grading of your embryos when you had embryo transfer?
So the first embryo that was that we had the misabortion was a 6AB, and then the second one that was a chemical pregnancy was a 5AB.
Dr. Sharara, I've seen records of patients who've had transfers of, you ready? CC blastocysts.
We don't even biopsy or freeze those.
We discard CC.
Yep, that's what we discard those. Yep. So definitely, you know, exactly as Dr. Roseff said, check your thyroid, check your vitamin D, check your prolactin, do an endometrial biopsy. All of these need to be done before you do an ERA. And I personally would not be surprised if you get endometritis. I mean, clearly they're having a very hard time getting to a thick lining, and there's multiple reasons for this.
But that's
I published a big review on this last year. There are many causes, but something as simple as inflammation of the lining is quite important. So if there is inflammation, you do the antibiotics for 2 weeks, and then go during a mid-cycle when you're getting ready to ovulate and just see what your lining is going to be on its own. And then during that cycle, you can get the endometrial biopsy done, repeat. So you need to have a repeat endometrial biopsy after that to make sure there's a cure. I've had patients who I treated them with one antibiotics, then I do another biopsy and it's still there. So you may need a different antibiotic for this.
I agree.
Okay.
The repeat biopsy is what I would call the proof of cure.
Yep.
And it has to be done.
Okay. I've already, I mean, we don't, no alcohol, no drugs, healthy. My husband is healthy. I'm gluten-free, sugar-free, dairy-free.
Perfect. And another thing I would strongly recommend, please do not over-exercise. Okay, that's another thing. There's been a couple of papers in the literature that if you do strenuous exercise, your chance of getting pregnant is 50% lower. So if you run all the time, that is a big factor for getting a thin lining also. Okay, so try to take it easy during this procedure. I would recommend nothing more than just fast walking. You can do elliptical 30-40 minutes max. You can do upper lower body weights, but nothing beyond that.
Okay.
Thank you so much. Thank you so much. Oh, we have another patient online. Preeti, are you there?
I'm here. Hey, I'm here.
Hello.
Hey, hello, doctor. Hey. Yeah, let me give you first a brief about the history, what happened. So it's like being now 1 year, we are in the IVF cycle, and in this 1 year, we have taken 4 attempts of frozen embryo transfer. Everything was good. Initially, we got like 23 eggs, and out of which my doctor, they froze 16. And I got like through testing also many testings because of the whenever we got the failures. So the question I'm having is like, within this 1 year we have taken like 4 attempts. So is it like too many attempts we have taken?
I mean, it's unusual for us to have somebody do 4 transfers without a pregnancy. So again, the question I'm sure Dr. Roseff is going to ask, were these embryos tested to see if they're genetically normal or not? Number 1. Yes. 2, you didn't tell us how old you are. 3, again, how thick did your lining get? What were the grading of the embryos that you have? I mean, all of these are critical for your chances of getting pregnant.
Okay, so yeah, my embryos got PGT tested. We got like 8 embryos PGT tested. Initially, in 3 attempts, we got the PGT tested embryos transferred, but none of them was a success. And in the last attempt, we got like 1 PGT and 1 non-PGT embryo. And my age is like, now I'm going to be like 36 soon. And my,
so you had PGTA normal, frozen embryo transfer fail, PGTA normal, second frozen embryo transfer fail, third PGTA normal, frozen embryo transfer fail. Is that what you said?
Yes. And in 4th,
there's clearly something major that's it's either being overlooked, missed, being done incorrectly. That is exceedingly not the norm.
Okay, because I got all the tests like ERA biopsy, the hysteroscopy test also, and I was on Lupron also for before one of the transfer. So it's like we are thinking is that like we are taking like so many attempts. Is that because we are getting these failures? And other question which I have is like, do I need to take a break now because of all these medicines I'm taking? And
What's the live birth rate? What's the pregnancy success rate with a frozen embryo transfer at your clinic? Do you know? Did anybody ever tell you?
70 to 80%, I guess.
It's not.
It's not, there's no way.
That's not true. That's not possible.
Okay. And means that's what it's like. And is it like how much should be the lining level? Because they call me on 12th day to test the lining, but really I never asked them and they never told me like what is the level, but they always say the level is very good and all my embryos were like excellent and all that. And you know, this time last time when we got one PGT tested and non-PGT tested, this time only the highest level of HCG which I got, it was 125. And but again that was not on this, that didn't get success later. And the thing is now the doctor is suggesting us to go for one more extraction, although initially they were saying that our embryos got PGT tested, we got like a 5A or 5BB embryos transferred, but none of them was success. And now they are saying that it might be like our embryos got compromised somehow and we should go for another extraction. Although we have like 2 PGT tested embryos left and 7 non-PGT embryos.
Hold on, Preeti. Why would they tell you these embryos were compromised? Did they tell you this?
Yeah, they told like that because they say otherwise there is nothing because
compromised how? I mean, if they were compromised in the lab, that's a huge thing.
Yeah, that's what we are like, we are surprised this time because it is like they are saying otherwise the levels are good, my lining and everything is good, and the embryos quality is also good. So they think that maybe while doing the PGT testing or while freezing those, something happened wrong. Otherwise it should not been happening.
But they're surviving the thaw. Do they give you pictures of the embryos when they transfer the embryos?
Yeah, and those are really good, they always say.
So if they look great, you know, so one thing I would have done after the first failed cycle is really do an ERA. If your hysteroscopy is normal, if your thyroid is normal, if your vitamin D is normal, if all the other tests that Dr. Roseff and I spoke about earlier are normal. Most of my Indian patients have very low vitamin D. So I put them on at least 5,000 every day. And, you know, I presented a couple of years ago an abstract looking specifically at my Indian patients versus Caucasians. And the pregnancy rate was lower in Indians. And the only thing that was different was the vitamin D.
Okay, so
we looked at every single thing. So if they haven't measured your vitamin D, make sure you go and get it tested. It should be at least 35, 40 when you do the transfer.
Okay.
Preeti, my advice to you is gather up all your records
and get a second opinion.
Seek out a second opinion. Something is
not right.
Something is not
right. And
by
the way, any center that tells you they have 70 to 80% success rate, as Dr. Roseff said, they're just lying to you. That's just not possible.
Yeah. And do you think that because we are going for like so many attempts, do I need to take a break now something? Or is
not necessarily. You need to try to get an answer.
Your break, the break that you
need
is
the second opinion.
Is to get the answer, right? To get the second opinion, to find out why this has failed. It's not that you need to take the break. You need to get to the bottom of, it's not the norm. You're not you may be thinking, well, it's just me. It's just me. It's not just you. There's something amiss here, and someone needs to tell you what the problem is or the problems are, and that clearly your clinic is not telling you. So you need to gather up your records and seek out a second opinion. If your clinic has a problem with that, then you're at the wrong clinic.
Preeti, when did they do? You said the hysteroscopy was normal. When was the last hysteroscopy you had?
they did before after my third transfer failure, because initially we got it done at some other clinic. They saw the report, they said like everything was okay. But after my third failure, they did the hysteroscopy and they saw some cyst or something. So they removed it also. So,
Did they do
That may have
biopsy or
left.
not?
yes, they did.
Okay, and
And
what?
like
And it did
everything-
not show any inflammation.
Yeah, nothing was there. They said like everything is good.
So,
You
but
need
that
to have that
question mark you
report.
said about something in the lining worries me a little bit. So
Oh.
if you have what's called polypoid endometrium, that embryo is not going to attach.
Okay. Means they say like always the lining is very good. I'm not sure. They didn't give me the numbers anytime. So is that okay? Because where we are going is the area, means they are like, we have seen like they are good. But so is that possible that I can send my reports to any one of you? Because we are in South Carolina. So if you guys can suggest us something that what we are missing.
Both Dr. Sharara and I have patients from all over the United States. I have patients in other countries. You probably do too. So one of the benefits of these virtual online consultations, which I'm doing all day long, is I have patients in Maryland, I have patients in New Jersey and New York, and I have a patient now in Texas. I have a patient now in the Bahamas, and we have patients from all over the world who seek out opinions. They electronically send us the records. You don't have to walk in with them. We review them. We do an online. I'm assuming you do the same thing, Fady. Same thing. We do an online virtual consultation. Give you the opinion after going through all the records, but we have to have time to review the records. Something is not right with your picture, and someone needs to find out what it is.
The last thing you want to do right now, Preeti, is to transfer another embryo.
Right.
Okay. So don't transfer any embryo. Take a break right now. You're not starting another IVF cycle. Get answers first before you do anything else.
Very good. Preeti, if you need contact information of Dr. Sharara or Dr. Roseff, just ask Riley and she'll connect both of you.
Okay.
Good luck, Preeti.
Very good. We're going to move to the next patients. We have 2 more patients. We try to get them ask their questions before the end of the webinar. Riley, who is first in the list?
Next patient is Joseph.
Joseph. Hello?
Hi, Joseph.
Yeah, you're muted.
Hello.
Hello.
Hi, how are you?
Hello. Can you hear me?
Yes.
Yes.
Okay.
Yes,
my question is just about women's cycle and probably window of implantation. First, I want to know, does a woman normal cycle has anything to do when the woman starts an IVF procedure? Like a woman that has a 25-day cycle and then decide to go for an IVF, and maybe she's using a donor egg, that she's not the one being stimulated, she was just placed on the progesterone and the rest just to tick the endometrium, and maybe the donor was being retrieved on day 15 and the embryo was cultured till blastocyst. So that's probably going to like 21 days, and she's having a 25-day cycle. Transferring the embryo on day 21 or day 22, does it have any effect on that cycle, being that she has a 25-day cycle and now she's going through IVF? Does it have any implication on implantation? That's my number one question.
And Joseph, are you a patient or are you a physician? Or?
The husband.
I'm a physician, a clinical embryologist. So this is just like an argument between me and my colleagues. So I said, let me put it on here and hear from.
Yeah,
ideally,
go
Joseph,
ahead.
ideally we'd like to take over from your that patient's cycle If somebody has a 25-day cycle, it means she's ovulating around day 10, 11 of her cycle, and that's way too early. So the best thing to do, since you're an embryologist, and I'm sure Dr. Roseff will agree, is freeze these embryos and then plan a frozen embryo transfer in that woman. So if she ovulates early, you can let her ovulate. A week later, you can start Lupron on her, have a period, and then go on estrogen. Those women who have diminished ovarian reserve, when they ovulate very early, it's very hard to time them with a natural cycle. So it's better to take over their cycle and then do a transfer. So the worst thing that should be done in this case is to do a fresh transfer from the donor into that patient's uterus. That is, I think, a recipe for a disaster.
I agree.
Good. We're going to take another question from another patient. Fernando, are you there?
I am. Hi.
Hello. Please proceed with your question.
Yeah, I have 3 quick questions. The first one is, what is the optimal estrogen level where my wife should be right before her transfer?
I'm not so sure there's an optimal level. I mean, it depends if they're doing a frozen cycle. In a frozen cycle, most of the cases are between 90 and 200, 250. If most of us use 6 milligrams of estradiol per day. So when you're doing a frozen transfer, it's not as critical. We've done sometimes vaginal estrogen where the value can be 2,000. So more importantly than the value of the estrogen is how thick your lining is.
And that's really the key. Follow-up question. What we know the lining, the thicker, the better. What is, if my wife's at low 8s, is that risky?
What is it?
Low egg count?
If my wife's lining is at about 8.
8 is normal.
It is normal. Okay.
Yes.
And I noticed that this session is being recorded. Will this be available for us to review later again?
Yes.
Perfect. Thank you, guys.
Good luck, Fernando.
It will be on the Progenesis website.
Progenesis, will do. Thank you.
Thank you so much.
Thank you.
Riley, next, do we have another patient online? There are certain, I see patient 3. I think that's probably the first patient that were asking the question earlier.
Yes.
Yeah, here.
Okay, we have Alicia as well. So let's go with Alicia first, and then I'll go with patient 3.
Okay.
Hi, hello.
Yep. Fantastic.
Yes, just I have my frozen embryo transfer yesterday, and I just want to have some tips or some recommendations you could have for.
Alicia, you dropped out. We didn't hear it.
Yeah, we have some technical issues.
You had a frozen embryo transfer yesterday.
I think.
Yeah,
just give me 1 second to connect with her. Sorry.
In the meantime, let's take patient number 3 while we're waiting for Alicia to connect back.
Okay, thank you so much. My question. Okay.
Alicia, are you there? Okay, go ahead.
Muted.
Proceed.
Yes, I just want some tips or recommendations you could have for frozen embryo transfer success implantation, and what to avoid during this couple of days that I will wait on my test pregnancy.
Dr. Roseff?
My patients are told to take it on the easy side the day of the embryo transfer and the next day. I don't mean bed rest. I don't mean that you have to be just doing nothing, but I tell them in the next 2 weeks, don't do anything strenuous. Don't over-exercise. Try to eat healthy. Try to keep your stress level down. Are you doing acupuncture or no?
No.
Okay. Just try to be.
I don't like the needles, so for me it's more stressful than.
Okay, if it stresses you out, it really doesn't hurt the acupuncture. But nonetheless, I was going to say if you were doing it, continue doing it. But just try to keep your stress levels down. Try to eat right, try to not over exercise, and
pray.
And yeah, and keep your fingers crossed.
Good luck, Alicia. Hopefully this is gonna work out. But don't stress out. Seriously, what's done is done. The rest now is not up to us anymore. Just take it easy. Don't do the things like Dr. Roseff told you, and just try to chill.
I could do like walks.
Yeah, you can definitely walk. We don't want you to stay home. Staying home, you're only going to fight with your husband. Don't do that. Just go out, take a nice walk. Weather is great. Make sure you're taking your supplements exactly as your doctor tells you to do.
Okay, and no coffee, right?
No, you can have one cup a day is perfectly fine. If you like coffee, you can have one. We're not telling our patients to basically become saints.
But when
not a huge cup, just a
he doesn't mean one of these. He means a regular cup.
Yeah. Okay, stay away from bad carbohydrates, no sodas, no recreational drugs. But most important thing, follow exactly what your doctors told you to do. That is probably the most important piece of advice I can give anybody.
Okay, perfect. Thank you very much.
Good luck.
We have one more question from patient 3. Hello?
Yes, I would like to know if it's possible, how much time does a patient have to wait in between the treatment? How much time that those medications flush out the body?
I mean, we give people medications every day because they're out of your system mostly in about 36 hours. So if you're taking any medication and you've done with the egg retrieval, those meds are outside of your system within a matter of few days.
Short time.
Dr. Roseff?
I agree. The stimulation medications are out of your body within, like Dr. Sharara said, a couple of days. If it's the hormones for frozen embryo, transfer cycle, FET cycle, by the time you stop them within a day or two, they're out of your system. So there's really nothing that I can think of that we use that stays in your body for a very prolonged period of time.
Well, thank you so much. We are coming to the end of the webinar. We had a lot of questions from patients that we were not able to answer due to the time limitation, but I promise that we can take your questions in the next webinar. With this, I would like to give you guys a minute to introduce your practice, and then we will proceed with closing. And I'll start with you, Dr. Sharara.
Well, I'm Fady Sharara. I run a small boutique program in the Washington, D.C. area called Virginia Center for Reproductive Medicine. I'm the only doctor. We do everything, donor egg surrogacy, IVF, the whole 9 yards. Nice place, great people, fantastic team, I think. And that's about it.
I can vouch for that. I've known Dr. Sharara for many, many years.
Thank you, Scott.
And he's one of a kind. He's unique. He's super smart. He's super caring. He's cutting edge. He's amazing. And I'm not just saying it because he's here. I don't have to say it, but it is true.
And Dr. Roseff is exactly the same. I mean, what we share is our patient philosophy. I mean, we really handheld our patients. We like our practices to run the way, if we were patients, what we would like to see in the center we're going to.
We treat our patients as if our patients are our own family.
Correct.
And if I treat you like my sister-in-law or my brother-in-law, and the treatment, the conversation, the discussion that we have at home on the couch is the same as what we have at the office, it's really the same. And
yeah. We really care, and that's, I think, what differentiates us. We really care. Sometimes we care more than some of the patients we have, but you know, what we tell you is because we care. And sometimes if we tell you something you don't want to hear, it's because we really need you to know what you're dealing with. We're not interested in taking your money. We're interested in you getting pregnant. We don't think of the finance part. We just care. And I really think that's what differentiates us from a lot of other docs out there.
Thank you so much. Dr. Roseff?
I am at a practice called IVF MD. We are the #1 fertility practice in the state of Florida. We have 6 office locations in Florida. We have 12 doctors in the practice. I'm in the Boca Raton, South Florida office. I'm board certified in reproductive endocrinology and infertility. I've been in practice for 31 years. I'm at the cutting edge of reproductive medicine. I'm doing things today that I was not doing 6 months ago. And it's part of what I love about having done this for so long, over 3 decades, because things are changing, things change all the time, things get better. And we always have to be 1 step ahead of everything, not doing day 3 embryo transfers. And that's what I love about what we do, is that it just gets better and better and better. Even though I'm part of a bigger group, our claim to fame, other than our success rate, is that we treat everybody as an individual. It's very hand-holding, individualized, personalized care. I oversee every aspect of what my patients do from start to finish. As I told one of the people on earlier, I have patients all over the country, if not from other countries. And the good thing about these, one of the benefits, honestly, of COVID, before COVID, I was doing these virtual consultations with patients on occasion in other states and other countries. Now I have patients who could literally walk to my office in Boca Raton, and we're still doing virtual consultations. They don't have to put on their mask. They don't have to get in the car, or they don't have to walk to the office or travel. So it really kind of brings the world into a smaller place. My motto is to do things once and to do them right and just make them work. That's always been my motto. And most of my patients, especially IVF, I level their playing field so that when they do it, it's going to have the highest chance it works first time, hopefully the only time, right out the gate. And that's me.
Thank you so much. Well, with this, we are coming to the end of the webinar. Questions and answers for this webinar. I would like to present my appreciation and gratitude for both of you, for Dr. Sharara and Dr. Roseff, for supporting the patients. Next week, we will have another webinar on fertility preservation options for cancer patients. That's on April 7th, 3 p.m. Pacific time. With this, thank you so much for joining us, and I will see you next week. Thank you so much.
Thank you, everyone. Nabil, Scott, pleasure.
Bye.
Thank you, everybody. Good night.
Thanks for having us.
Bye-bye.
Bye-bye.